I think that in terms of giving the diagnosis of cancer to a child, how you do it and what you say is very, very age dependent, and not just age dependent, but on the emotional and intellectual growth ladder of the child. I think that every child needs to be told in some way that they have cancer, and try to give them some understanding of it. Of course, a 2-year-old, you're not going to say much to. My youngest patient with neuroendocrine tumor was 6, I think, and a 6-year-old can understand that they're going to have to go to the doctor a lot. They can't really understand that you might die from cancer. So I try to, first of all, it's sometimes very hard to tell the parents. And I usually, with this age child, a child under 10, tell the parents first, and then ask them if they would like to come with me to tell their child. Some will say, no, we don't want the child to know, and I always respect that. But I think children understand that they're sick, and that they are, they might have to go to the doctor often, and that they might have to get chemotherapy. They know after one treatment what it means. And for that reason, we always have child life specialists on our team who helps them through every single, treatment and every single visit. And that, again, so that's the younger kids, age 10 and younger, I would say. When you get into preteens and adolescents and young adults, they understand what cancer is. And I think it's important. I don't think you can keep it from them. But again, I tell the parents the information, and then ask them to come with me to tell. I think it's important for that to be done together, because I think it's important for the doctor to tell the child what in the doctor's mind this means. And actually the doctor can say, which I can say with a child who has a neuroendocrine tumor, I'm going to be able to help you have a better life. And I always tell them with a neuroendocrine tumor, I don't have any treatment right now that will cure your tumor, but we're working on it. And I even invite them into my lab to see what we're doing in research. And I think this, gives them a sense of hope. And the older they are, the closer to a young adult they are, the more they understand. But I really, the bottom line is, I do think they need to know. I think they know more than we give them credit for most of the time.
Absolutely.
And I think it's important for both the parents and the doctor to tell them that. Well, I don't know that I'm seeing a lot more children. Part of that is because we now have not just Iowa, but we have several centers around the United States that have pediatric oncologists dedicated to neuroendocrine tumor diagnosis. But I think overall, we're recognizing these sooner, and that's contributing to the increase in diagnosis. Whether there's anything in addition to that, it's difficult to tell at this point. So I think the best reason we have now for the number of cases increasing are better diagnostic methods. And I would put in that category, I would put endoscopic ultrasound as right at the top of the list for not just identifying small bowel neuroendocrine tumors, but also pancreatic neuroendocrine tumors. And then I would put the gallium dotatok or dotatate PET scan next on the list, because, you know, our CTs, whether you're taking a CT or an MRI of the liver, the chest, or the pelvis, those are our three main areas. We can see very small, maybe less than 1 millimeter on the PET scan we can see less than 1 millimeter on a CT scan or an MRI. But the ability to put the gallium PET scan together with that and have the digital capability to overlay those two scans and say, oh, that little spot that we saw on the CT scan lights up. That's made us much more sensitive. Well, one of the ways, because there are not many pediatric oncologists who take care of children with neuroendocrine tumors, one of the things that I like to do is I can see a patient here at the University of Iowa, make contact with the doctor closer to your home, and then we can manage this together. Most pediatric facilities, I think we're the only pediatric facility that would actually treat a child with PRRT. So for those, you would not be able to get it, probably closer to your home. I would help you find a physician, including a pediatric oncologist who would be able to work with us together to manage a child who had a neuroendocrine tumor. If your pediatrician is willing to call me or send me an email, I will work with them. And I think most of the pediatric oncologists that I know who work in neuroendocrine tumors will do the same. And sometimes it's hard to get, sometimes, let's say your child has diarrhea. Well, there's so many causes of diarrhea. Maybe the pediatrician is embarrassed to call, a specialist halfway across the United States for a child who has diarrhea. So, sometimes that's the hardest part, but they can always send me an email. And if they, I can sometimes take, 3 or 4 or 5 days. Like today, I'm way behind on my email. But I'll get back to them. And usually once we start an email conversation or have a phone conversation, then we can work together. Well, I'm hopeful that we're going to be diagnosing these earlier, that it's not going to be 4 or 5 years of misery for a child who has an intestinal neuroendocrine tumor or pancreatic neuroendocrine tumor, and that we will, number one, that we'll be able to diagnose most of these and get the primary tumor out. And that's still the only cure we have. And I think we should be trying harder and harder to get that cure for those kids that we can. I use the gallium dotatate scan more generously than many of my colleagues, because I think a negative scan helps us a lot, especially if you have what you can call non-specific symptoms. So meaning that they have symptoms that can be caused by a lot of different things. So flushing, well, I mean, I flushed an awful lot as a kid because I was very shy. So that doesn't mean I had a neuroendocrine tumor. But you can get a sense, if flushing is a big problem, then maybe we should look into it a little more. Same way with diarrhea, same way with constipation. And if I can use a gallium scan to be able to rule out a tumor, I never say I'm 100% sure you don't have a tumor, but I can say I'm 98 or 99% sure that you don't have a tumor, and then we'll follow up. So I think earlier diagnosis is going to be our biggest advantage. And I think surgery is going to always stay as a very important part of our therapy. I do think that alpha therapy is going to down the line replace the therapies that we have now with yttrium-90 and lutetium. I think our genetic analysis is becoming more sophisticated every day. It's a rare tumor, so if we do the genetics on leukemia, and there are, thousands and thousands of people with leukemia, even thousands of kids with leukemia, then the genetics are easier to do. We're setting up at Iowa we call it a consortium. So we have 6 institutions that see neuroendocrine tumors who are going to compile our data together. And I think and the National Cancer Institute wants then to enlarge this to include anyone, any institution that sees neuroendocrine tumors. And once we get that many people in that much genetic information in the database, we'll be able to look more carefully and identify genetic causes, both the ones that we know about now and ones that we don't know about. And I think that's going to be a big way that we can do better at making earlier diagnoses. So to me, earlier diagnosis is really the key.